Okay, I see we're almost up to 30 now, so I think we can start. For those of you who just joined, also a warm welcome to all of you. Thanks a lot for carving out the time to participate in today's webinar, which I at least think promises to be a really interesting session. My name is Janneke van Oorschot, and I'm a research officer at Health Action International, and I'm also coordinating HAI's AI program. And before we start, just a notice that this session is being recorded. Okay, so before we take off, I'll first give you some background and some insights into the reason why we are having this webinar. And then I'll hand over the words to our two wonderful speakers of today. I'll be sure to keep it short so that we have plenty of time to dive into the contents. So most of you will definitely know this, but the AI Act, just very briefly, is a new piece of EU legislation. It's a horizontal legal framework which regulates uses of AI in the EU. The health sector sparks major interest when it comes to using predictive or automated decision systems to improve health and care. There's really an incredible amount of research and investments in such technologies, some of which have intended uses within the traditional healthcare system, but many also outside of that. Think about health apps or disease outbreak monitoring tools, which were used during COVID-19. So this field is diverse. And despite the high interest in developing health technologies from medical companies, tech companies, but also research groups and others, there's actually a stark lack of consideration of the health sector in the AI Act. For example, only medical devices which are subject to a third-party conformity assessment under the Medical Devices Regulation, and AI systems which are used for the dispatchment of emergency care are classified as high risk under the AI Act, and therefore subject to a conformity assessment. But as you can see in the next slide, maybe you can show the next slide, Alice. Yes, thank you. AI in the health sector is actually so much broader than that, as I already mentioned. And shouldn't we have measures to guarantee the quality of those systems? So that's just one point to make. We also noticed there's quite a limited civil society voice on the AI Act in the context of health, as opposed to quite a strong lobby from big tech and big medical tech companies. So that summarizes the reason for having this webinar, and I'm glad it's drawing quite a good audience today. We have two great speakers. The first one is Sofia Palmieri, who is a PhD researcher at Ghent University within the Metamedica research group. Her research studies how regulation can ensure the safe, patient-centered, and evidence-based use of AI in the medical field. And she has also published work on the intersection of the AI Act and the Medical Devices Regulation. Our second speaker is Hanna van Kolfschooten, who is a PhD researcher and a lecturer at the Law Center for Health and Life at the University of Amsterdam. Similarly to Sofia, in her PhD, she studies the EU regulation of algorithmic decision-making in public health and healthcare, and how to safeguard patients' rights. Next to that, she's also contributing with her legal expertise to the work of HAI's AI team. So in today's webinar, we've chosen a concrete use case, which is AI in elder care. We've noticed that it really helps in thinking through risks and issues to have these very concrete examples. So after this brief introduction of me, Hanna will introduce this use case. Then to make the session thought-provoking, we then have Hanna's and Sofia's presentations centered around several statements, which they will reflect on and provide their perspectives on. Some of these statements may seem a bit simplistic or provocative, but they are also arguments which we still see are being used or sometimes are implicit assumptions of arguments. And then after the presentations, we will hopefully have about 15 minutes left for a Q&A. So if you have any questions during the presentations, please put them in the chat, then we line them up to be discussed after. So now I've given you already quite a lot of information, but without further ado, I now like to give the word to Hannah to share the case of AI in elder care. Thank you, Hannah.
Thank you so much for joining this webinar. I think it's really important that we also show the other side of the debate on medical AI, because so far it has been mostly dominated by MedTech companies, but also companies that develop pharmaceutical products. So it's good to have you here to also show the more fundamental rights side of things. I'll present to you now a case that's actually already being used in multiple care centers for elder people. It's a system called Care Predict, but you also have a lot of similar systems that really resemble this system. So this is just one company, but a lot of other companies are actually offering the same product. So this product, Care Predict, is a platform that's now used in senior care facilities. So this is both medical care, but also living assistance. And it has a lot of different features, ranging from fall detection through the use of motion sensors and also cameras. It also has a lot of GPS signals. So we always know where people are going, as we know that especially elder people with certain neurological conditions have the tendency to wander off. There's a mode for family view, so they can watch their loved ones via the camera. And it's also possible to do a two-way voice system, so you can talk to people while they're in senior living care. And all of these systems, and there's more, I just named a few of them. You can also see them here on the website of Care Predict. They are built to really improve senior care and also make senior care more accessible and less expensive, and take out the really overburdened systems that we have right now in especially senior care, but also healthcare in general. These are, of course, very promising results, but we also see, and there's been a lot of research about this, that there are very big challenges to both the quality of the care that senior people receive with these kind of systems in place, and also fundamental rights protection. So first, I want to shortly introduce you to these challenges that we see before we move on to statements that Sofia and me are going to reflect on. So if we look at the use of AI in elderly care, we see that this can actually impact the quality of care. There are many examples of that the data that's being used to train these kind of algorithms and to develop these kind of systems is not always the best available data, also because it's sometimes very hard to get high quality data. And as we often say with AI, it's garbage in, garbage out. So if we don't have access to high quality training data, then also the algorithms will not always function as well as they should. So there's still a big risk that the AI, monitoring AI, will miss big events, which will eventually lead to less quality of care because, for example, the fall detection doesn't work properly. We also see that in this training data that's used to develop these algorithms, there's often biases. And this can be both gender and racial bias. So if the algorithm was trained on a specific set of data that did not include this specific gender or race, then the algorithm may function not as well. An example is that facial recognition cameras, for example, also emotion recognition cameras, function not as well on people with a black skin color because it was mostly trained on people with a white skin color, which can in this case mean that the algorithm will not function as well for black people as it would for white people. Another example that we have is that of cultural bias, because most of these data that's available is of Western cultures. So there are examples that if people are bowing down on the ground to pray, that the system detected it as a fall. Also the other way around, that it would monitor whether the elder people in the care homes would eat properly, but then it was only meant for people using a fork and a knife and not people using chopsticks to eat. So it wouldn't detect that. So all of these biases in the training data can really lead to worse outcomes of care, especially if you compare it to the human systems of care. Another big problem we have is, of course, privacy intrusion, because these people are monitored all the time. We collect all of their vital signs. We have cameras installed. We also listen in via audio, and they really do not have a private space at all anymore. And this can, of course, also lead to a lot of fear and distrust in the system, especially with people who are already maybe because of old age, more vulnerable to distrusting technologies and maybe also distrusting governments. So this can have an even bigger impact on elderly people who do not always understand technology. Another thing we fear, and we also see coming from research on these kind of systems, is that leads to dehumanization of healthcare, because often the human care is replaced with these kind of systems, which can also lead to social isolation, because before someone would come in a few times a day to check if someone's doing well, and now you would only come in if you got a notification from the system. Another risk is that eventually this will lead to commercialization of vulnerable groups, like in this case, elderly people, and then especially when it comes to collecting these huge amounts of personal data in all ways possible of someone's life in a care home, that can be used for different reasons and really take advantage of these people who do not often do not realize what is happening and what are the risks of these kind of systems. So this is just an example of how medical AI can be used in a health setting, and of the fundamental rights risks that already occur and can also occur in other systems, and do not only have impact on fundamental rights of people, but also on the health of people. And now I'll give the floor to my colleague Sofia, who will reflect on the first statement.
Thank you, Anna, for the nice introduction to our discussion. I think we are both quite comfortable with our statements, but nonetheless, since we are really passionate with the topic, we are quite nervous. So in case of question later, we can all discuss together. But my first statement for today is we do not need the AI Act to regulate medical AI, since the medical device regulation offers enough protection for fundamental rights. And in this case, we all think that is false in this between the panelists. Firstly, because the medical device regulation and the AI Act, of course, move from the same desiderata of the European Union. What does it mean? That they both the tools wants to offer fundamental rights protection through the use of safety requirements, but then the outcome that they arrive to achieve is pretty different. Why? Because the application of the two regulations have a different extension. Let me explain why. So the AI Act offer broader application and covers tools and devices that are not covered by the medical device regulation, that has specific requirement to be identified as a medical device. So even whether a device is not under the medical device regulation, can still fall into the AI Act. Why? Because it can be just for the fact that the AI Act define AI in a really broad way. So the tool can just reflect the AI definition proposed by the AI Act. And in that case, it falls within the AI Act. But it can also be a tool that in different degrees enters the AI Act, because it can be a minimal risk AI or a high-risk AI, even though like it's not a medical device under the medical device regulation. And I think the elderly care the elderly care example is a good example in this sense. Recently, I was writing a paper on healthcare robotics, and we realized that all those robotics that were used for care of elderly people, not therapeutics function, that do falls within the medical device regulation, but care functions, so way more blurry in the function itself, do not fall in the medical device regulation, but may fall into the machinery regulation, and therefore anyway being a high-risk AI under the AI Act. In the second case, and this happened in many other cases, especially for some tools that we will discuss in the next slide, some devices fall in a minimal risk AI class. And this is not really satisfactory from a legal point of view, because in that case, we will see that the regulation do not provide the requirements for minimal risk AI that can still potentially breaches fundamental rights. So I think this is my statement for now.
Thank you. Then I'll go on to the next one. You've probably seen this statement going around since the early 90s, mainly coming from pharmaceutical companies, which is more regulation will delay access to life-saving medical devices. And also MedTech companies have been shouting this all over the place since the AI Act first came in the media. And we think that this statement is false. And that's mainly because we really believe that medical AI can only be life-saving when we're very certain that it meets high quality and safety standards. So in that way, more regulations, so more checks, more technical requirements are the only way to really guarantee that a medical device is safe and will eventually be life-saving. It's also because we believe that medical AI holds much more risk to health and also fundamental rights of patients than other medical devices, which has to do with that it acts for some parts autonomously, and also it uses a lot of systems that are not always very transparent, and therefore leave doctors and their judgments out of the equations, but will still be used for a lot of medical devices in very important decisions that will impact on the health of patients. So what we see is that indeed this AI regulation adds some more requirements and regulation to medical devices than we have now, but it also adds a layer of quality and safety requirements on top of this medical devices regime that we already have for medical device using AI, which can eventually also lead to better quality of medical devices and thus better health of patients using them. Just a small example, you probably all remember this, but a few years ago we had a big scandal in the media about, we call it now the implant files, which had to do with the many medical devices that were on the market that were not safe for patients. So we know the stories about the breast silicone implants that made many, many women all over the world very sick. And in this case, we saw, for example, in the Netherlands, a Dutch journalist who got a CE mark, so an approval for a medical device that was actually a clementine net. So you see it here on the picture. He filed all the documents, he gave all the information, and then the private body that had to decide on a medical devices approval said, okay, this is a perfectly safe medical device, you can use this as an implant. Well, that shows already how not strict this medical devices regime is that we have right now. Also because we use these private notifying bodies, and this shows a very less strictly regulated regime if we compare it to medicines. While we also know that at some point AI is going to be used and medical devices are going to be used just as much as we use medicines now. So to me, it seems strange that we have this very light regime for medical devices and then would also deny this extra layer of AI Act protection if we talk about AI in medical devices, because we know already how risky these medical devices can be if we do not even use AI. So to us, this is also a false statement.
So health and well-being app do not hold the risk for fundamental rights violation. And this is really interesting for me because I do think that well-being apps really present a concrete use case of how the AI Act falls short in healthcare. Because indeed, as I said before, it does add something to the medical device regulation, but it doesn't mean that it is effective in what it's adding. Okay, so for example, in following the AI Act, health and well-being apps fall into the minimal risk AI. So in that case, they do not have to satisfy any kind of requirement because the risk connected to the intended use of these apps do not seem to represent a really high risk for fundamental rights. However, these kind of apps represent a risk because they use enormous amount of health data. And we know from the recent examples, for example, overseas after Roe versus Wade, for example, that many femtech app have been presented many privacy-related risks. So first of all, the privacy-related dangers are really well known and well documented in the literature. But beside that, we have so many other kind of risk for fundamental rights. First of all, non-discrimination, for example. And these discrimination issues are really frequent also in well-being apps. And I take again the example of the femtech app, because I think it's really an example that tackles a really sensitive matter for women's health. And in the case of pregnancy related applications, they are developed in a within a data set that do represent only a partial number of all what women could represent, meaning that the data do not represent the broad, vast nature of women using this kind of data, of this kind of apps. And I think women could feel like discriminated, could feel pressured in their really intimate experience of pregnancies using these kind of applications because they do not feel represented by this kind of application. Beside that, we also experienced, and is well documented in the literature, problems with the right to life and right to health related to post-traumatic syndromes app that, for example, were using data training data, not really of high quality. And in that case, we had many applications that were not really responding to the need of the patient, but on the contrary, suggesting things that were not really appropriate to the syndrome that they were supposed to treat. And I think this is really dangerous because we are treating people that are way vulnerable. So we really have to pay attention to that. And besides that, we really have many cybersecurity issues that once again, I could bring the example of femtech because we have seen overseas, again, examples of tech companies breaching into these femtech applications in order to bring some data and get better advertisement for women in those contexts of marketing. So indeed, once again, the AI Act is not paying attention to this kind of fundamental rights violation when it comes to health and well-being app, as well as for many other minimal risk AI that are misclassified.
Thank you, Sofia. I'll move to the next one now, which is safety of elder patients trumps the protection of privacy. This is also something we hear a lot in the public debate, that privacy is not as important as health. Also, we saw it in when COVID just started, that many governments said, okay, this is such a big health crisis. Privacy is not as important anymore. We just have to solve this health crisis now. And we also see that now that the risks of the pandemic have become less, that the same argument is still around in healthcare. And especially when it comes to elder patients, which I also just showed in a use case at the beginning. This is also a false statement, we believe, because privacy is a fundamental right. And it means that, first of all, you have to have the minimum requirements for fundamental rights in place, and you should always protect at least the personal data of people who are being subjected to medical AI devices, and also protect their personal sphere as well as possible. And this is the minimum. So only if you have this minimum sufficiently protected, then you can go on and develop devices for elder patients. And we all believe that it has to do with the key value of human dignity, that if you do not believe that elder patients have a right to fundamental rights protection, then you're not appreciating their human dignity. And human dignity is really the basis of all of our fundamental rights. And we also believe that this is connected to the fact that privacy is a key condition for trust in healthcare. So if we do not appreciate that there's a certain personal space that a person has, then we also know, we saw this in the HIV pandemic also, that people will not actually go to a healthcare professional anymore and share their personal information because they cannot trust that this personal information will keep secret. So also the reason that we have in the medical profession this medical secrecy is also because otherwise people will not access healthcare and we will have a much bigger problem. Another thing we see is that constant surveillance really changes behavior. So we have these examples already from the 18th century, for example, in prisons, that if you know that you're being watched all the time, then you will change your behavior, even though you're not perfectly certain that you're being watched at that moment. Just the possibility that someone can be watching you can already change your behavior. And we saw this also in the example in the beginning, that many elder patients actually said, yeah, I know that there are not cameras in the bathroom, so sometimes I hide in the bathroom because I don't want to burden anyone, because I don't want them to come to me because they see that I'm in pain. Or I know that if I have a certain expression on my face, that they will come in and I want to be alone right now. So they will actually change their behavior because they know they're being watched. And another thing that also has to do with privacy is that we know that many elder people and patients, they fear technology, and this fear will only become bigger if we cannot guarantee that their personal data is really protected. So this is why we believe this statement is false. So we do not think that the safety of elder patients is more important than privacy, because privacy should be the basic value.
Thanks, Hannah, for moving to the next slide. So a couple of days ago, we were discussing this statement and we couldn't avoid smiling because for me, high quality healthcare is more important than fundamental rights protection. It's kind of a contradiction in terms. And why? Because quality of care is kind of a complicated concept. That is clear. We do not have a clear definition, a really line one of what is quality of care. But we do know that we have some pillars that describe what quality of care implied. And I think all of these pillars represent somehow fundamental rights, imply fundamental rights protection. Let me explain better. Quality of care imply 3 pillars mainly according to the OECD. And they are safety, evidence-based medicine, and patient-centeredness. And all of them in different measures imply the safety as a fundamental base of fundamental right protection. Evidence-based medicine in itself, in its core, take into consideration patient values, and patient values are also the respect of fundamental rights. And beside patient-centeredness, that seems quite of a repetition, but it's not. Patient-centeredness is kind of the idea that medicine, and in this case, technologies that are related to healthcare, needs to take into consideration to have at their core the respect of fundamental rights. They have to be implemented with fundamental rights protection into their functioning, okay? So once again, kind of the concept of trustworthiness again comes again in this discussion. So I think, no, high quality of healthcare is not more important, but just because it cannot happen without fundamental rights protection.
Thank you, Sofia. I'll move on to the last statement, which is actually one that we believe is true. Medical AI always needs a human in the loop. As you may know, this has been a discussion also in the development of the AI Act, discussion about the stop button, discussion about you should have the right to choose whether an AI will look at your case, for example, a legal case, or a human judge. And we really believe that this is especially important if we talk about medical AI. And that's because we believe that healthcare is the most human, most personal sector there is, and it should never be dehumanized. We don't see a future where you're just being treated by a medical AI, some cool technology. We always believe that there should be a human available to you and also involved in this decision, just to make sure that everything goes well, and also to make sure that you will remain your trust in this healthcare system. So healthcare should never be dehumanized. We realize that there is already a right to human intervention in the GDPR, but if we look at this closely as lawyers, then we see that this Article 22 is not directly applicable to healthcare, mainly because of this very strict conditions that this article has. So we don't think that this right that we have right now in GDPR is enough when it comes to patients, and will not sufficiently protect patients and give them access to a human in the loop. Also, at this point, if we look at the AI proposal, there are no effective mechanisms proposed for actual human oversight. And we believe that this really should be included in the proposal, because it's very important for patients that they also have a human perspective on their case, especially when it comes to their body and their health. We do believe, however, that this person, this human in the loop, should not be just a box checker, checking the boxes, but actually be a very knowledgeable person that knows what's going on, not only on a technical basis, also on a healthcare basis, and also actually has the possibility to stop or change a certain action that is proposed by the medical AI. This means that also, because before people are going to argue that, okay, but that's not always possible because AI is very complicated. That also means, indeed, that we should not implement black box medical AI in a hospital setting. So we can only use AI that's actually able to be checked by humans. With this statement, I like to give the word back to Janneke. Thanks a lot.
Thank you, Hannah and Sofia, for these insightful presentations. I think we now have a little bit more than 20 minutes left for questions, and so that's great. So if you have a question, please put them in the chat now. And perhaps as people are formulating their questions, I can start off. Because during your presentations, we've heard about many risks, and you've already touched upon this a bit in your presentations as well. But if you were to mention action points of what needs to change in the AI Act to ensure fundamental rights protection in the health sector, what would be your main recommendations? Maybe you want to both answer this question. So I don't know who wants to go first. Sofia?
It's the same as you wish, Anna. Shall I go? Thanks. So first of all, what comes naturally from my side of the presentation is really that when it comes to minimal risk AI, we do have a problem. So we can describe that problem in two ways. Or we have too low requirements for minimal risk AI, but I don't think this is the right formulation, but rather we should maybe reevaluate how do we classify minimal risk AI, in the sense that it's clear that these well-being apps, for example, do represent some risk for fundamental rights. So maybe the question is not really imposing new requirements on AI uses that maybe do not represent any kind of risk, but be certain that what falls within the minimal risk class is really without any risk for fundamental rights. So this is the first from my side. But I also want to add something else. Yesterday, I was going through the new version of the AI Act, the one approved, voted in November. And I realized that in Article 2, like while describing the scope of the AI Act, they kind of point out that system used for purposes which fall outside of the competencies of the European Union are excluded from the regulation. So it kind of comes as a natural question for Hannah and I think, to wonder whether AI uses in healthcare in general falls outside of the regulation, since healthcare is really not a competence of the European Union. So it's really something that, in my opinion, needs way clearer definition, and we need to clarify as soon as possible. Also because otherwise all this consideration will be null, and we will need another instrument just for healthcare. This is from my side.
Yeah,
Yes, Hannah, please.
Sorry. Just adding to you, Sofia, I think I hadn't seen that yet, but it's interesting. But I do think that we could agree that at this moment, AI is considered a product.
Absolutely.
Everything that enters the internal market, also apps, are already governed by the GDPR. Also, if it's health and well-being apps, so maybe that's enough to fall within the scope of the EU.
It's the other side of the coin. But I was, when I read the line, I was really wondering, is it just, do we have to look at it just from the product perspective, or also from the other side? So what really concern us, so healthcare perspective. Yeah. And it's really right there. We already had doubts about public safety. Yeah. So whether also public health will come to be excluded. But in this case, it seems even more likely.
Yeah, that could be the case. Yeah, but so maybe medical devices are definitely in there. I think also apps, if they're used for consumers, but maybe public health will be an issue. Yeah, it's interesting. I would like to add, if we could still change the AI Act, which is not certain that there's still room to do that, but if we could, I would say that right now it's really focused on the development phase. Well, actually, when it comes to AI products, the most noticeable risk, they only come to effect when it's used in a healthcare setting. So I think really this use phase should be regulated also in the AI Act. And that's not just for health, that's for all AI applications. And then if you also regulate this use phase, it would make sense to also include some individual rights for people who are being subject to AI applications, because right now it's only requirements on the side of the developers and the deployers of AI, but not the people who are actually whose personal data is in the end used for the AI.
Yeah, sorry, Janneke, may I add something? Because yes, what Hannah just said, like, light something in my mind. And I was thinking about I think we already discussed this partially, Anna, like the use of the concept of intended use within the AI Act. I think it's quite a tricky one, since actually, if we think about AI as a product, everything is all right, but AI has also the potential of innovating itself. So what if it change its intended use? Like, is it just like using the product just in another way. So it's on the user. It's like, and it's not just a matter of liability that comes right after this consideration, but it's really how to be sure that the intended use that has been certified and to which all the requirements come in a consequence is going to be the same for all the lifetime of the AI. And I'm not sure whether the new AI Act has any kind of insight on this.
Okay, yeah, thanks for that answer. Very elaborate insights, very important points raised. I see in the chat we now have a question from Luciana, who is saying, could you give an example of what might happen if we leave AI technologies that are used in elder care classified as low or minimal risk technologies? So I think, Hannah, in your case, you already gave some examples, but perhaps you have some more examples you would like to share.
Well, I think so that's the case now, right? Because we don't have an AI Act in place, we only have the medical device regulation in place. And of course, GDPR. So that means that everything that's related to directly personal data is covered under the GDPR. For example, when to ask for informed consent to use personal data. But what including it as high risk in the AI Act would add is that there are more requirements, especially on the quality of data that has to be used for training the AI systems, so you can at least limit the risk for bias. Also, there are stricter monitoring requirements. There's more on cybersecurity, which is a huge risk, especially when you use these intrusive AI devices. Well, there are examples of hacking pacemakers, so it could really directly harm people using these devices. So, and I also believe that this is also a really big market in general for MedTech companies. So if we leave this unregulated, then more companies will probably jump in this gap and develop more of these applications and cause more harm because it's not regulated. So that are the risks that I see.
Do you have anything to add, Sofia?
I was thinking to a very picturesque example. So I was thinking about a wheelchair AI power that is really something that we are already experiencing in senior residents. And imagine that this wheelchair is perfectly capable of regulate the speed and the seat itself and how it should move around without many inputs from the side of the patient. But like, if it's a minimal risk AI, that is not, I think, in this case precise, but in the case of through the medical device regulation, we do not fall into the high risk AI, then we have kind of a lacking of cybersecurity requirements that could lead to the wheelchair to just raise the speed or not following the commands that we're supposed to follow, you know? So it's an hilarious example, but actually it's really dangerous also because we are always talking about people that has slower reflex or that cannot really deal with this kind of technologies by themselves. So we really need to be certain that the data and the systems that are deployed in their building are really, really of high quality.
Yeah, thank you for that. Oh, yeah, sure.
Just adding to this example is that I visited the AI lab in Brussels last year, and they were developing this wheelchair there. So it was really in the early phases, but this wheelchair both had, it was AI regulated, but it had motion detection, so it would not bump into walls, for example. But they were still in the developing phase, mainly figuring out how to also not make it speed away from the person who wanted to get into the wheelchair. So the error in the system right now was that if you approach it from some angles, it will just run away from you. So this is also a very like, of course, they still needed to do a lot of work on this too, and they were going to further develop this algorithm, but just to also give you a clear image of what can happen if the algorithm does have a lot of errors because it was trained on, for example, someone stepping in a wheelchair from the left side and not from the right side. That actually you can end up having to change your wheelchair.
Yeah, thank you for that. From both of your answers, it's just astonishing to me that these systems are still not under the high risk category in the AI Act. So thank you for that. Another question here I see in the chat is from Catherine, who says, if you don't manage to get these changes into the AI Act, which might not be possible by this stage, indeed, are there other opportunities to get these questions addressed in other regulation? So, Anna?
Yeah, I would say there's still a lot to win in a medical device regulation itself. So then we're talking about, well, only health AI that's also a medical device. But like I mentioned before, the regime right now is very light. It's really based on information that's provided by the developers. They have to state their intended use. And then private notified bodies make these decisions, sometimes resulting in giving CE marking for ridiculous products. So I think there's still a lot to win in medical device regulation itself and make it a lot stricter like we have with pharmaceutical products. And I think another thing would be to maybe not change the GDPR, but at least provide some more guidelines on how to use health data under the GDPR. Because right now it's really vague also for medical research companies working with health data, how exactly they can use this and how it should be shared and how informed consent should work. So I think there's really a role for the European Commission to clarify this, or maybe the Data Protection Board to give some more guidance on how we should interpret these provisions on health data. I think that could help also.
Thank you. Sophia, do you have anything to add to Hanne's answer?
Yeah, certainly. So I won't focus on the GDPR because it's definitely more Hannah's competence. But what comes to my mind is, for example, the renewed General Safety Product Regulation, or it's a directive. I think it's a directive. And in that case, I think they were focusing, for example, on self-learning systems, so systems that can implement themselves and kind of innovate what they do. And also, so we go back to the intended use problem. And I think definitely those kind of regulations find partial applicability where the AI Act do not find applicability. This is really interesting because it's a matter of European law. So when a more specific regulation has something to say on the matter, so the ad hoc regulation for a certain matter, then that regulation applies. Otherwise, when we do not have answer for something, we do look for something in other kind of regulations, such as the General Safety Product Regulation. So it should be clarified indeed. And your question is really relevant in this regard, whether the General Safety Regulation find application with regard to the minimal risk AI.
Yeah, thank you. So it seems like there are more opportunities to still improve other regulations that will impact health AI. Another question is from Sylvia, who says, what impacts can this AI Act have on ambient assisted living technologies? It's a very specific question, but who of you would like to take it?
I don't know, Sofia, maybe you could specify a little bit, because I would say that actually the same risks that apply for the device that I just mentioned, elder care, would also apply for ambient assisting living technologies, with the extra risk that not all of these technologies will be medical devices. So that means that you do not even have the extra requirements coming from the AI Act, but just the low risk category, which actually means that there has to be transparency about that AI is being used.
Yes.
So does not answer your question, and maybe you can specify a little bit in the chat, or Sofia, maybe you have something to add.
Yeah, I have just a general remark. Like, so this is a good shot, Sylvia, because it's a really tricky question. So I would say that ambient assisted living are based on general AI. And the last version of the AI Act talk about general AI, specifying that they do have to follow the same requirements of the high-risk AI in which eventually they are embedded. So this is what I would say about it. Like, I'm not sure, like, ambient assisted living can be intended for many, many different uses. So it's a bit of a general question, but I think these kind of systems are based on speech recognition, for example, that is a general AI. And in that case, they will have to satisfy the requirements that comes with the specific intended use that they are gonna implement through the general AI. I don't know if I have been clear enough.
Yeah, that makes sense to me.
Okay.
Thank you.
That's relieving.
I see there's one more question in the chat. So I think that's maybe the final question we can take. It reads, it's from Martina, who says, thank you very much for your considerations and very valuable, important points. Let me see. I wonder if AI deployment should be looked treating like a medical drug development. You mandatorily need to have clinical trials in different phases to prove its safety, its efficiency, and its applicability in the real world and community. Sorry, I was stumbling a bit over my words here, but I hope you got to the question. Hannah?
Yes, that's a very good idea to me, especially for if we use AI like in actual healthcare, so the most risky types of AI, I think it's very strange that they only have to do pre-marketing assessments and do not have to go to the same clinical trials that we have for pharmaceuticals, except especially because I think that at some point we will be using more medical devices than pharmaceuticals. So I actually think that we should head that way. Exactly.
Yeah, I do think it's a correct insight, and I think also that the AI Act tried to implement in a really clumsy way, but tried to implement the same perspective, because I think somewhere is written that the data governance, so the sufficient data quality has to be proved also in the real life setting of employment, but I'm not sure whether this is feasible. So this is feasible following the diktat of the AI Act, while I do think is the right approach, the one that you suggest, as also Hannah said. So yes.
Okay, thank you, Sofia. So some practical considerations there with making this idea reality, maybe. Are there any further questions? I'll just give people a few more seconds to put in questions in the comments box. If they have any, this is your chance. And if not, I will move on with closing the session. So let me see. I think at the moment, I don't see any further questions, just compliments to you both. So please take those in. So then I would just like to thank you a lot for, thank everyone a lot for their active participation. And then just some final bits of information is that for DJ Santé, we are leading a thematic network on AI and health inequality together with Brunel University. And over the coming months, we will be developing a joint statement, which will be presented to the European Commission. And we very much appreciate input from all kinds of stakeholders in health and digital rights. to this joint statement. So please register in the EU health policy platform if you want to be kept informed on this process. You can see a link to this health policy platform here in the chat. My colleague Alice has just shared it, so thank you for that, Alice. With that, I'd like to give my huge thanks to our two amazing speakers today and to everyone who joined this webinar. And I'm wishing you all a really good rest of your day. Thank you.